when I was given this, I thought, how could I'm going to try and make this interactive with a few questions out to you guys, just to try and keep you on your toes. Yeah, so, and please feel free to ask questions. So I know quite a few of you out there, and it's lovely to see you all, and it's lovely to be back at a meeting again where we can meet face to face. And just as a bit of a background, because you're probably wondering why I'm doing a knee talk, and because on the coast, traditionally I've been doing quite a lot of foot and ankle, but actually my background is in knees, and I did a really high-end sports fellowship in Brisbane with doing the Wallabies and the Broncos and the Reds, and then went to Toronto for more knee surgery. And then I came to the Gold Coast and I was asked to do a bit of foot and ankle, and then it kind of grew from there. And so I got a bit typecast. And so now that we've actually had a foot and ankle surgeon join our practice, and I'm very lucky now to be able to focus on what I really enjoy, so knees. So we've got an excellent foot and ankle surgeon in our practice called Steve Nicol, who's taken over all the feet from me, and I can now focus on knees. And my interests are really, joint replacements, unfortunately, are very, very common, but it's actually trying to protect young people's knees, keep them active, and try to avoid joint replacements if we can. So today I'm really going to talk about a few different knee injuries and how to evaluate them, but really almost as a case-based discussion, and then please feel free to ask questions throughout. So case number one, Becky. She's really excited that COVID lockdown has ended. She hasn't been training quite as hard as normal, and she's got back into footy, and she's a really good footy player, and she jumped for a mark, landed, and she immediately felt pain in her knee. So, question to you guys, what are the possible injuries? I'm going to read out, so ACL tear, torn meniscus, muscle tear, patellar dislocation, or all of the above. Yeah, exactly right. Yeah, the story isn't enough. But what is really interesting, and the more and more I get into knees, is you can really pick a lot just from the history. Yeah, and it's not just the history of the injury, but then also of the next few hours and days of how the knee has responded. And sometimes now patients will actually bring in a video on their phone of how they injured themselves. It's really interesting to have a look at. When I was in Brisbane with Pete, he'd often be on, he'd be watching his athletes on Fox Sports, and he'd come in and he'd have videoed the injury, and they would see the guy later in the day, and it's fascinating to assess how they've injured themselves. So near the end of the game, so a bit of fatigue, someone bumped her in the air, so she's going up for a mark, and she was not in control as coming down, which is quite common, especially in the elite level players, how they injure themselves, because they're so well trained and they're such finely honed athletes. When she landed, her knee popped out and back in. She felt a crack, and there was immediate swelling, and she was unable to fully weight bear. So back to that same question, likely injury. Happy for you to, but to me, sounds like a ACL. Could be a torn meniscus. Could be a patellar dislocation. So certainly doesn't rule out everything. And the other thing is, on the history of an ACL, be cautious. Sometimes people say, well, actually I got up and the knee wasn't that bad, and I managed to play on a bit, but then anytime I tried to sidestep or change direction, it gave way. So it's amazing how the difference in severity of injury that we see. So examining her, large effusion, she had quite a lot of muscle spasms, so she wasn't allowing a full range of motion. She turned her over the lateral joint line, and she had limited range of motion. So, examination test. Now, with a sore, stiff, painful knee that's splintered, we can't do a lot of these. The McMurray's test is a rotational test looking for meniscus pathology. Hard to do. The research says it's probably not very accurate anyway. Passive range of motion, probably important to assess, but not push it too hard. Anterior jaw test, patellar apprehension test, or Lockman test. Of those kind of tests, do we know which one might be the most accurate for an ACL tear if we're thinking ACL? Yeah, actually the Lockman supposedly is a more sensitive and specific test, but it's really hard to do. And if you have small hands, I'm lucky to have reasonably big hands, and I also examine a lot of patients under anaesthetic. So, but if you have small hands, it's quite a hard one to do as well. So definitely the anterior jaw is your first starting point. I'm going to show you a video right now. Yeah. So as I said, I'm lucky. I get a lot of patients asleep under anesthetic, so it's easy to examine them. So anterior draw, knee at 90 degrees. Holding your thumbs, and the easiest way to hold is actually thumbs over the tib tub, so you actually can assess the movement of the tib tub. And you're looking at the kind of femoral condyle here and the motion of the tibia versus the femur to see how much motion. And you're looking for more movement than the other side. And the movement, the ACL stops that anterior movement. So if the ACL is ruptured, we get increased movement, to put it simply. So here's a video of an anterior draw. And it's actually not that positive. We're about to do an ACL reconstruction, but we call that a grade 1. I'll show you one more time. So there's a couple of millimeters of excess movement of that tibia coming forward. So compare that to a Lockman, nice skinny leg, and once again, big hands. Now you can see a Lockman is different. So this is examined at 30 degrees of flexion. Try to get their hamstrings relaxed. And you're immobilizing the femur with one hand. And once again, you're trying to see the shift of the tibia on the femur. With really big legs, the other way to do it is to bend your knee under the crease of their knee and push their femur down into your knee. So you're immobilizing the femur and then trying to pull their tibia forward. And I've had to use that on some of the big rugby players. That's the way you have to go sometimes. So I'll show you once again the difference. Anterior draw, not very positive and not, as we said, the research not so specific. And a Lockman, and you can really see the big difference. That's a positive, very positive Lockman, and this is the other knee of the same patient with a tiny bit of movement, but negative. Everybody happy with those?
Is it still possible to get those kind of signs in the acute knee?
Yes.
Okay.
Now, yes and no.
Okay.
With a swollen, painful, splintered knee, that unfortunately you see them 1 or 2 weeks after the injury if they haven't looked after them. It's really hard. Some of the little tricks that I use when I see them like that, you're trying to get them to relax their hamstrings because the hammies in spasm stop you from doing that. And so a couple of times, don't know if I did it on this one. No. So sometimes actually what I do there is I'm holding the leg and I just kind of just give a little bit of a wiggle of the tibia. I'm not going to hurt you. I'm not going to hurt you. Just relax. And it's not a painful movement. So you're just trying to let them know you've got it all under control and then relax those hammies. But it's really hard. Another big Lockman before surgery. Patients had a nerve block, hence that pink. And then we take them through range of motion and then we do a pivot test, which I wouldn't ask you to do. It's hard to do in an awake patient. But a pivot shift test is a test essentially reproducing the movement, the rotational movement that blew the ACL in the first place. And so what we're doing is I've got the foot internally rotated and I'm applying a bit of a valgus force. So, I don't expect, I have trouble in a lot of patients doing this when they're awake. But what you'll see is the tibia is actually subluxed when the knee is straight and it's coming down and clunking back into position. And this is how the injury occurs when they tear their ACL. Plunk. And so patients hate that because it actually reproduces the injury. One more time. And it's easy when a patient's asleep. Yeah. So that's a hard test to do, and it's not often that you get a positive result in an acute knee, so I wouldn't say you need to do that. You can't do that if there's a big meniscus tear, if there is an MCL injury or another ligamentous injury. So once again, without a scan, I see these patients with scans as well, so I know that I'm not going to be causing other damage. So I would probably leave the pivot it's there, but I wouldn't do it. Just some other assessments. So looking down on the knee, and once again, assessing the collateral ligaments at about 20 to 30 degrees. Once again, nice skinny knee. So this is one of the he's a mountain bike multi-ligament knee injury, and that's his lateral collateral structures are gone. But you can see also how it rotates. So it's a rotational thing. So the MCL just goes, but the whole femur's trying to rotate on me, and I have to hold it really hard. So that's a tough one to assess. And I've got the normal side just to show you there's not much movement. So the difference in the two injuries. So an acute ACL tear, they're getting more frequent. 70% are non-contact injuries. So you don't always have someone running into you and causing the injury. It's usually coming down from a jump, so from a mark, changing direction or sidestepping is that mechanism, and the knee gives way. They often feel a pop or a crack or something, a clunk. There's often immediate pain, and swelling usually occurs because the ACL is a very vascular structure. The swelling inside the knee or the knee effusion develops usually within the first 6 to 12 hours. And some people feel unstable afterwards. Some people with that swollen, stiff knee, by the time you see them, haven't had the chance to feel unstable because they've just been hobbling around. And often because of the degree of injury, they've torn a meniscus or they've got other injuries, cartilage injuries or other things. And risk factors for ACLs, there's some that we can't modify. Sadly, women, especially younger women, have a higher risk of tearing their ACL due to a number of different reasons. There is clear evidence that it's genetically linked as well, and it seems to run in families, and ligamentous laxity can be associated with ACL tear as well. And then there are a lot of modifiable risk factors, and unfortunately this is something that we, as a whole profession, but particularly orthopaedics, we know about, and Christopher Tudor has done a lot of work on making the awareness that there are things we can do to minimize the risk, but we aren't very good at doing it as a nation as yet. So a lot of sports are high risk, so the ones that have a lot of twisting, pivoting and jumping. Sports specialization where we don't fall out of trees. And you know, when we all grew up, we were falling out of trees and doing silly stuff, and we therefore developed the protective mechanisms that aren't associated with one specific sport. Overtraining and then undertraining, so how much is too much, who knows. And definitely screen time has been linked with ACL tears. And you can see the difference here in these two athletes as they come down from a jump. And we can train people to land with our knees slightly outwards rather than in a valgus position, because the valgus position puts people at risk when you come down from a landing of tearing your ACL. So what's the initial management of an ACL tear? Edema control, ice, anti-inflammatories, some early physio, crutches, knee brace. I think they're all appropriate. They're absolutely. It can be as simple as an isolated ACL, or it could be as complex as a fracture with an ACL with a meniscus tear or something else. So I tend to play it safe. If someone comes in and sees me, they've got a stiff swollen knee with or without a scan, if they're hobbling, put them on crutches, you know, because otherwise they then develop abnormal gait patterns which are really hard for our physios to fix. They get more painful because hobbling on a stiff, painful knee gets more painful and they get stiffer. So crutches, I think, are probably more protective than a knee brace. Lots and lots of ice, and seeing a physiotherapist early can be really, really beneficial to try and overcome that initial acute injury. Any questions about that? We used to aspirate them quite a lot to get the hemarthrosis out. I don't do that ever anymore. I'm not sure that it's a hugely beneficial thing, because we tend to find that it just reaccumulates again. So it's definitely something that I don't see very often.
The official Robert Jones bandage, that's out now.
Compression actually is not a bad idea. So definitely if you find it helps, I think that's fine. But I think that combined with some icing, so trying to pulse that with icing is very helpful. I'm not a big fan of heat, but some people love heat on it. But I think that we're trying to minimize the inflammation, so I think ice seems to be better.
Do you have a time frame when you say trying to avoid the brace? So they get to, say, a month after the surgery, trying to get rid of the brace?
Yeah, well, for me, that all depends on if there's an associated ligament injury. So if we have an MCL injury, that actually is highly likely to heal. Most MCL injuries with an ACL will still heal back to a normal MCL, and they need bracing. So it depends on what other injury. But if it's an isolated ACL, I'd be trying to get out of the brace by a month, if not sooner, if possible. Any other questions? So exactly what we've said. And really, I think it's not inappropriate to send for an X-ray with some of the mechanisms. You know, if they're really sore and non-weight bearing, rule out a fracture. Really important to do that. we're seeing fewer and fewer, but we still see some people with an ultrasound scan and a CT scan, which I don't think really adds that much unless there's a query. A CT scan if there's a query of a fracture on an X-ray, but otherwise a CT scan doesn't really help. The difficulty is if someone has a contraindication for MR, but these are still younger patients, so typically they don't have a contraindication. And preventing further injury, I think it's really important. So that's why I think the crutches are quite safe and helpful to stop a further injury. And then refer if appropriate. Now, who are we going to refer? Sorry, before we go on to that. Question. ACL rupture increases the risk of arthritis. True or false? True, yeah, no matter what we do. People can function without an ACL reconstruction. True. ACL reconstruction stops that risk of arthritis. False. Return to twisting, pivoting sports is safe without reconstruction. False. Yeah. Surgery less than 6 months from injury reduces risk of meniscus cartilage damage. In the evidence where people are still playing sport, it's true. The other thing is early ACL reconstruction in manual workers and labourers also has been associated with an earlier return to work as well. So, not saying that everybody needs an ACL reconstruction. It's a very individual discussion we have with everybody. But there are certain people where you'd certainly be thinking sooner rather than later. So not everyone needs an ACL. I think if people are a few months down the line from their ACL injury and they have ongoing instability, I think that's a discussion to be had with those patients. If they haven't had an appropriate course of physio, then that's worth trying. If it's my knee, I wouldn't be having an ACL reconstruction immediately. I'd be doing some rehab and seeing. So definitely, I think in Australia we do quite a lot of ACL reconstructions, and there are a lot of reasons why. But I think that we don't always let people work out if they need it or not. Definitely the younger people is very appropriate to be doing. Plan to return to high-risk sports. I think trying to train to get back to sport with an ACL deficient knee, and especially if it's a pivoting, twisting sport, you're going to spend 3 months doing that and then tear a meniscus or something else. So I think those patients are the ones that we do say, I'd probably get in and do it now so that you're onto your rehab, rather, because we know that they're going to have ongoing instability. If there's a significant meniscus tear, now I've said bucket handle tear, and I'll explain what that is in a second, but a significant meniscus tear, because those don't heal, and the meniscus is really important for the long-term survival of a knee and not getting arthritis. And then a cartilage injury. So meniscus or cartilage injuries, significant ones, you can't repair those, and they won't heal without stability in the knee. So, a bucket handle meniscus tear. Now, actually, one of my colleagues who was a hand surgeon said, up till I got to the final fellowship exams, I didn't know what a locked knee really meant, because a locked knee sounds like it's a knee that doesn't move, and it's a silly name to describe it. So a locked knee is a knee that has a block to full extension compared to the other side. So a lot of patients walk around with a slight FFD, and that's normal. But if the other side extends, or quite often they have a bit of hyperextension, whereas the knee is in about 10 degrees of flexion, and they can flex it up. Sometimes if it's an acute knee, it will flex to 90, but no further. That's what a locked knee is, and that is because the meniscus, so normally a meniscus is a nice round structure of cartilage, but there's a circumferential tear around the periphery, allowing half the meniscus to flip into the middle of the knee. And so this shouldn't be there, and it blocks the knee from coming straight. So that's what a bucket handle meniscus tear is. And in a young person, that's often losing 50% or more of the meniscus, and that's an important load-bearing structure. So in those patients, we want to try to repair those if we can. Any questions about that? I was very happy when the hand surgeon said he didn't know something. So X-ray, rule out a fracture. An MRI, unfortunately, and luckily, we're very lucky now, MRI is very easy to obtain, mostly. But really, that's the one. I'm very happy to diagnose an ACL tear without an MRI, but it's the associated injuries that are quite important to have that discussion with patients as well. Because that not only does that impact how I might guide their management, but also what their recovery is like and what their likelihood of having a normal knee is. And really, as I said, an ultrasound scan or a CT scan isn't so helpful nowadays. And so plain X-ray and then into an MRI. So I know that you don't often get to see the images, often you see the reports, but I thought I'd show you what we get to see. So I'm sorry, it's not projecting that well. Can we dim the front lights for a sec, or is it possible? So it's not projecting that well, but this is the femur and the tibia and the patella, and you can see just the edge of the PCL here, and the ACL should be a nice straight line of fibres coming up through the back of the knee from the tibia to the femur. It's really not projecting well, I do apologise. But so this is an ACL here, and you can see that there's a rupture there on the vague blurred pictures. You can look at them on my screen later if you wanted. And the other thing that we see very clearly quite often in acute injury is this bone bruising. So that bone bruising on the femur is associated then with a bone bruise at the back of the tibia. So that has banged against that. So it's a huge rotational injury that has caused the ACL tear. And then that's an ACL reconstruction in comparison. So they're not projecting well, but so we're getting pretty good now at reconstructing ACLs anatomically so that we're getting our graft pretty similar to an existing ACL. So definitive management, as I said, so not everybody needs an ACL reconstruction. Consider it if there's going to a plan to return to high-risk sport or employment. As I said, labourers, manual workers with ongoing instability, people working on uneven ground. I think it's worth considering. Younger patients, definitely. People who've done some rehab but have developed functional instability where they just don't trust their knee. Those with ligamentous laxity. There's a bit of talk out there, you might have heard about ACL repair. So reconstruction is where we actually use a graft of something and create it, and it turns into a new ligament over a year. Whereas repair is where you stitch it back into the right spot. And there's quite a lot of research going on, and certainly in the States there are some intriguing results, but certainly it's still experimental. And in all of the data, it's probably a slightly higher failure rate if you look at the true data. So it's not something that is recommended to most people. So how can we, and in the COVID times, and who knows what's coming again with China now locking down again, how can we delay ACL reconstruction if people can't make it in for surgery or surgery is cancelled? So we don't want to cause further damage in an ACL deficient knee. And that requires a patient who's going to be diligent with their physiotherapy to regain strength and control and proprioception, probably advising them to avoid the sport or the twist, the high risk activity that they want to be doing. So that's the hard discussion to be having, especially in teenagers. And trying to retrain the high risk maneuvers. As I showed you that picture of the landing, learning how to land a jump like that rather than like that. And those are things that can be trained. It requires a very committed and motivated patient who's willing to listen, experienced physiotherapists who know about that sort of rehab, and access to a gym, I believe. And then, I sometimes say, well, look, if we have to delay it, have you thought about other, because a lot of the younger people just have that competitive drive, and it doesn't matter what they're doing, they just need to compete. So I say, well, how about swimming or road cycling, or, which has risks, I know, but doing something else competitive to keep you out of soccer until you've had your knee stabilized. So it's a hard discussion to have, but I think that's certainly something we've been seeing over the last 2 years where we can't do the surgery when we want to. And the education is vital. So if they're suffering ongoing instability, there's a high chance that they're causing further damage. So that's really when it's time to think about doing something about it. ACL reconstruction. So I was saying to Timur, it's amazing. We have a majority. We give people mostly a stable knee, but the re-rupture or re-injury rate is still about 10%. So actually, when you look at that, would I be happy having an operation with a 90% success rate or 10% failure rate? It's not great. So even though we think we're quite good at it, I think there's still a lot more that we don't know and we aren't so good at. So, and that's not just my data. That's worldwide data. That it's good, but it's not perfect. And there's a lot of research into how we can improve the outcomes with adding little bits of ligament reconstructions on the outside of the knee, for instance, to try and give a more stable knee. And only about 60% of people return to their pre-injury level of sport. So no matter whether they've done the perfect rehab and the perfect surgery, not everyone returns. And whether that's psychological, they don't want to re-injure themselves again and they've been through a year of hell, or they just don't risk it. It's really interesting, but so we don't know why. Younger people have a massively increased risk of re-injury, whether to that knee or to the other knee. And reconstruction has not been shown at the moment to stop you from developing arthritis. We hope and think that it is better now than it was 10 years ago, the surgery, and we think that it probably, hopefully will just delay that surgery, the risk of arthritis far more than what it used to do. But it hasn't been shown yet to stop it from developing. And then very, very finally, as I mentioned, there are programs out there now which are well published that can reduce the risk of knee injury by about 50%. That's not my stomach, that's someone drilling. I haven't had breakfast. And there are a whole load of different free resources out there, and some were developed in Australia for different sports, where you can do this program for 6 or 8 weeks. And so if I've had someone who's had surgery, or someone whose brother or sister has injured their ACL, I say, get in to do this, and you can do it. It takes 20 minutes before a game, so you can use it as your warm-up, and you can halve the risk of knee injury. Yeah. Any questions about ACLs? Yes, sir.
Your average, accountant who hurt his knee skiing,
Yeah.
he's obviously not a high-risk person, but he's got an ACL injury.
Yeah.
What would you offer them? Because assuming they want to ski again in
Yeah.
1 or 2 years.
Yeah. Well, I think that's the thing, is what do you want to do in a year's time? Because skiing, so there's a very famous French surgeon who, and they've shown that skiing is probably the highest risk sport for tearing your ACL and ongoing instability, because you've got such a long lever arm on your strap to your foot. So I'll probably be having a discussion of the pros and cons of surgery and a reconstruction, but it depends on what they want to do and what their, how old they are as well. But certainly an ACL reconstruction in a very active skier who wants to return to skiing isn't inappropriate. Anyone else? What would your discussion be? What would you say to him?
I'd say the same thing. It's
Yeah.
like, do you want to go skiing or do you want to go to the Bahamas?
Yeah, exactly right. Yeah.
You can do either, but if you want to go skiing, you might need an operation.
Exactly. Yeah.
And rehab is obviously beneficial, motivated patients. You've got this guy, he's a shooting thing person, he's got some resources behind him. What sort of improvement do you get with rehab compared to not just waiting and seeing if your knee's unstable?
Yeah.
Is there a definitive massive improvement, or it's probably a bit better?
I think it's huge. I think that rehab is important either without surgery and also with surgery. I think it's 50% of the result of an operation. So I think rehab's vital, and they're way more likely to avoid an operation if they want to by doing a really good rehab program, because they can train. It's not just strength, it's actually the other stuff that's the most important. It's the proprioceptive and the control that's the most important part. So it's absolutely vital in my mind. Any other questions? Okay, Kale. It's a true patient name. Yeah. So 38-year-old yoga instructor and barista, he had to be with a name like that. Nominative determination, wasn't it? A gradual increase in deep knee pain, worst while squatting, which clearly is impacting his yoga instructing. And he's limited with deep flexion when twisting on the knee. What do we think might be causing his pain? Yeah, probably. Could be a Baker's cyst. I think that, so Baker's cyst, the terminology, but it's a popliteal cyst, or a parameniscal cyst, usually goes hand in hand with a meniscus tear or meniscus pathology. Could be early arthritis, not unreasonable to consider that. Probably not. That's more seen with running athletes and change in what they're doing. Could be that, with deep flexion. Depends where the pain is, I guess. So twisted the knee a few months ago. Bit of pain and swelling at the time. settled over 2 to 3 weeks, but still, he's returned to activities, but it's still a bit sore. He can still run, he can still work out, and he can do most yoga things. As you can tell, I'm not a yogi, I haven't a clue, so hold most yoga positions, I think that's about kind of made that up last night. So we're now honing in on a diagnosis which is likely to be, tender over the medial joint line, small effusion, positive meniscus provocation test. Now I apologise, I meant to try to video me doing a meniscus provocation test, but as I said, none of the meniscus provocation tests, McMurray's tests, are actually that sensitive or specific. But what we're trying to do is take the knee through a range of motion whilst twisting and loading the medial and then the lateral meniscus. So I'm happy to try to show you one later, but they're not that helpful anyway, because if you've got arthritis, it's sore. If you've got a few other things, it's sore as well. So I find that the joint line tenderness and really having a good feel around the side of the joint, and usually it's around the posterior part of the joint, is probably the most helpful test. And the history. So investigation? Yeah, MRI. We do get some ultrasounds saying there's possible meniscus pathology. The only trouble with that, I find, is it doesn't help me to decide what I can and can't do for it. So for me, unfortunately, it has to be an MRI. But if you wanted to kind of say, well, I think it's meniscus, I would get an X-ray, make sure there's no arthritis, because I think that's so a weight-bearing X-ray, because a lot of radiology centres don't automatically do a weight-bearing X-ray, and there's a big difference in what you can see with a weight-bearing X-ray. And then an ultrasound may say, yeah, there's probably meniscus pathology with no arthritis on the X-ray. So then you can then tell that patient that's probably what they've got. So we had an MRI, and I've got the pictures, which are probably not going to project very well. A complex tear through the posterior horn of the medial meniscus with otherwise normal knee. Oh, here we go. So this is an example. This is the same patient. Lateral side. So when we see an MRI through the side views, the sagittal views, the meniscus is a C-shaped disc, and we've got two, and it's taking a slice every 3 millimeters. So we're seeing a black structure, the front of the anterior horn of the lateral, and the posterior horn lateral meniscus there. And what we don't want is white lines through them, basically. So here we have the anterior horn of the medial meniscus, and it doesn't project well, unfortunately, but there's a kind of complex line going through here. So there's a complex tear through the medial meniscus of this young person. And often the history, as we said from Kale, there is often twisting on the standing leg or deep flexion. They often get immediate pain. Swelling can take a bit longer. The meniscus doesn't have a great blood supply, so if they're going to get an effusion, it might take 12 to 24 hours. They may never get a real effusion, and it often does cause ongoing pain with twisting and flexion. May get some mechanical symptoms. So that's another term, like locked knees, that you hear all the time, but what does it mean? Mechanical symptoms is something is loose or floating or moving in the joint, so they can feel something loose, something locking, something clicking, or something catching. So, management. I think the first two definitely appropriate. Yes and no intra-articular injections. I think they can be beneficial for the right patient. They definitely don't want surgery, or some of the people who might be called Kale don't ever want any form of intervention, and they just want stem cells or something, and that's fine. You're not going to do any harm. I'm not a fan of repeated intra-articular steroid injections. I think that's one may be okay, but in younger people there might be some detriment. But all of these two, fine. Definitely not that. And then we'll just discuss meniscectomy, because that's been the common treatment that orthopaedic surgeons have used over the years for a meniscus tear, is just chop out the meniscus.
Sorry, do you mean PRP injection?
Yes, and well, I'm not sure. I don't really know. The evidence shows much difference between all of the three types. So I think of cortisone, PRP, and then the Synvisc or the synthetic joint fluid replacement. They all have similar-ish results from what I've seen. So
not very good.
Yeah, but definitely not for those meniscus tears. No. Yeah. So I think they're worth trying if patients aren't keen on intervention. I think that's, some people get better on their own, and some meniscus tears, a lot of meniscus tears get better on their own. And so trying to keep people going while it's going to heal itself is a bit of a battle sometimes, isn't it?
What kind of duration of time for healing?
So, in a degenerate meniscus tear, we're saying 80% are going to get better over 3 to 4 months. So it's similar to that disc prolapse kind of story. If they've got a mild degenerate tear, try to manage them for 3 or 4 months and they should get better.
I just need to tell it because they're always like, you say it like, you're like, oh, it's going to get better. And you're like, how long?
Yeah, and it's sore.
Yeah.
It's really sore sometimes.
Yeah.
So this is my opinion, and you'll find different surgeons have different opinions. So the meniscus is a very important load-bearing structure, and on the medial meniscus it carries about 50% body weight, and the lateral meniscus about 60% of the body weight. And when you're running and doing things, it's even more. And so losing meniscus volume, a significant volume, or function leads to cartilage overload, and that can lead to pain and then eventually arthritis. And I try to describe it as a tire to patients. So when you've got a heavy truck and they've got 4 tires, then those tires are sharing the load going down through the cartilage and protecting the knee. If you then lose 2 tires and then potentially lose the rubber on the tire, then you're loading on that rim and you're causing damage to the other structures. And so it really is quite easy to talk to people about it being a car tire. So you get wear and tear, and you get different levels of wear and tear. So just a bit of degeneration, and often these are going to be okay. You wouldn't want to be driving on that, but that one's probably going to be okay. And you may just say, okay, well, just keep going and it'll get better on its own. But I was looking for slashed car tire, and I found all these photos of policemen slashing car tires in America. So anyway, so if you've had an injury that has effectively just slashed the tire so the rubber's gone and you're down on the rim within minutes like that, that's the type of injury that is not going to get better and where we would think about doing a repair. So we talked about the bucket handle meniscus tear, that should be repaired. Younger people, tears with an ACL associated injury, or a newer injury that we're starting to see more and more in the middle to older ages called a meniscus root tear, we should try to repair, because if we can put the meniscus back to its function, we can stop them from degenerating and getting rapid onset arthritis. So unfortunately, Kale had a meniscectomy, and this is not by me, this is an MRI 6 months after a meniscectomy in a 38-year-old, and we got no meniscus. So it was a very aggressive meniscectomy, and what I wanted to show is it's hard to see, but the cartilage is this light grey colour, and it's thinned out almost completely within 6 months. And then there's a bit of bone edema already, so the whole medial compartment is crying out because it's suddenly lost. It would have been better just to leave that meniscus rather than go in and do a meniscectomy. So for me, I think meniscectomy has its role, and sometimes it's all we can do, but an aggressive meniscectomy taking out most of the meniscus should be, I think it's something in the past, and you're better off leaving it than actually chopping it out. And then the meniscus root tear is, everyone would have seen someone like this. So usually it's a 40 or 50-year-old, often female, and they had a bit of niggle in their knees over the last years, but not too bad, and they're really active and they walk kilometers a day, and then they miss a step or they twist on the knee and bang, and suddenly the knee's swollen up and they can't walk on it anymore. And that story, that's one of the people in their 40s or 50s who don't get a bulk build scan anymore, but boy, if they're over 50, 55, 50, where that's probably where I'd be getting a scan quite soon if it's not settling within a couple of weeks, because this is one of the ones where the knee will sort of run down pretty quickly. So just an idea, so that's the lateral meniscus, and the medial meniscus is right at the back where it attaches to the bone, and the medial meniscus is just gone. And so it effectively just defunctions that meniscus straight away. It's like taking the slash across the tire, and they've lost that buffer. And it loses its ability to do its job, and they can often get worse. So this is effectively what it is. So this is the meniscus attached to the bone, and then there's a tear through the back there, and it just stops it from working. So we try to repair those if we can. Any questions on meniscuses? Timo?
I think in the past, in the public system, you wouldn't do anything, and somebody over 40 who's got a meniscus there, and then you would just wait until the knee degenerates.
Yeah.
Is that still the case, or is the approach slightly different?
everyone has their own opinion. There's not a right answer, but I think that it all depends on the patient and their function and the type of tear. So, with an MRI scan, we can decide if it's one that potentially is repairable, or whether it's one that's just a degenerate associated with arthritis. And those are the ones that definitely I'd be saying, look, leave this 3 or 4 months and it should settle down to how it was. Does that answer your question? No? Yes? Yeah.
When is it too late to then do anything about it if you waited 3 or 4 months and things haven't quite improved?
I think, in my mind, most meniscus tears have the best outcome from repair around up to about 6 months if we can do it. The ones that are much harder to repair are the bucket handle meniscus, because as I showed you in that picture, it's in the knee and it's being squished with every single step they take. So those ones are urgent. We should be fixing those in a couple of weeks. But otherwise, I think most other tears we could have a good attempt at fixing it within around up to around 6 months, maybe even longer.
Physio, weight loss?
Absolutely, all absolutely vital and really important. And the hard thing is meniscus repair results. They're good. I do a lot of teaching and research on meniscus, but probably only 80% success rate with a meniscus to heal, and the recovery is 3 or 4 months. And if you're telling someone you're going to be on crutches for 6 weeks, and then it's going to take another 2 months to get stronger and get back to normal, and there's a 20% chance you're not going to be much better. So it's a really hard discussion to have with some of these patients, especially when they've already got some pre-existing arthritis in there. But I still think, trying to repair it, just not chopping it out, I think is the way to go.
And is there any information on, like there's a lot of people, Kale for instance, would be interested in nutrition aspects in terms of what could he eat that will help it to heal better?
Yeah.
Is there any information yet?
There is not a lot in the orthopaedic literature, there's not a lot. And in the generalised medical literature, there's not, but I'm sure there's some out there. There's a really interesting, so not for Kale, but a really amazing research study which was randomised, placebo-controlled and crossover for obese people with knee arthritis. And they showed 20 grams of dried strawberries versus a pink shake. They got better pain, better function, and actually lower cartilage degeneration products in their blood tests compared to the ones taking the shake, and then they crossed them over. So there is definitely a lot of impact we can have on diet, on muscle, on weight loss, but we just don't know what it is. Yeah. I tell every patient that now, go and get some dried strawberries. I had one patient who emailed me and said it worked, so that was great. Okay, final patient. How are we going for time?
About 5 minutes.
Okay.
Let's go home.
All right. Millie loves dancing, regular gymnastics. She was dancing by the pool at a friend's birthday. She slipped, twisted her knee, the knee popped, and there was severe pain. Pretty much all of the above again, isn't it?
Yeah.
So, Millie, she's had knock knees all of her life. So she's got that kind of, we call it miserable malalignment for these patients. They're often knock knee, flat-footed, a bit rotated. She's got ligamentous laxity. She felt her, and they often say knee. They don't know what that means, but she felt her knee pop out, and then the ambos came and they managed to pop it back in. So, what's that?
Dislocation.
Yeah, patellar dislocation. Yeah. And then they went to ED. They waited for 6 hours, and they were X-rays are fine. Nothing's wrong with you. Just sprained your knee. So we've said it, patellar dislocation. So patellar dislocations. There are two very distinct types of people. There's the athletic or not athletic person who has a blow to the side of their kneecap, which forces the knee out, and they've never had any issues with their patella in the past. And so that's a traumatic ligamentous injury. So they've ruptured their MPFL, which is the medial patellofemoral ligament. And that's the most common, direct blow. And then we have the patients who are really that unfortunate, like Millie, who have got a primary instability, meaning they've got abnormal anatomy. And the anatomy starts probably from the pelvis down, where they have valgus knees, and they often have malrotation in their femurs and tibias. They have a high riding patella, and because of all of these abnormalities, when their patella and the groove, the trochlear groove it sits in, are developing, they probably develop dysplasia. So it's almost similar to hip dysplasia, where they don't have the normal forces through it, so it doesn't develop normally. And they often may or may not have ligamentous laxity or a connective tissue disease as well. I have a video, it doesn't work, so I'll put it on at the end of the talk, of patellar dray tracking, which is one of the easy signs anyone can see if you look for it carefully enough, and I'll put it on at the end. So the initial management of a first-time patellar dislocator. Any ideas? Yeah. So actually it's interesting, it's quite controversial. We hate stiffening up joints and we hate putting them in splints, but there is a little bit of evidence, it's not strong evidence, but in a first-time dislocator, if you splint them straight for about 4 to 6 weeks, but try to keep them doing some quads co-contractions and some other muscle contractions, you may be able to lower the risk of redislocation. And probably because we're letting the patella sit in the right spot and letting that ligament, which tends to heal, but it's healing in a tighter fashion. So it's not strong evidence. If patients are against it, don't do it. But I've had a couple of patients who are higher level 16-year-old athletes who haven't had further dislocations from that management so far. Managed swelling, they're often very, very swollen and sore, so loads of ice, anti-inflammatories. I've now got more aggressive with an MRI, so any first-time dislocation, I think that's the injury that requires the greatest force. So the next one, the subsequent ones often need less force, and I think that's the greatest chance of having injury to cartilage. And so I get an MRI with that first-time dislocation to rule out a significant cartilage injury, and then looking for the risk factors. And so the management is, after we've splintered or not splintered, treat the pain or swelling, regain range of motion, and then recover good strength. Now, we always tell patients it's your inner quad, and that's really important, and it is really important, but actually there's increasing evidence from good research from the physios that you actually have to work on the core, the glutes, the core, because once again, it's that coming down, landing like that, or like that if you can control that, like that, then your kneecap is going to be more central. Because my quads, if I contract my quads, it automatically wants to pull my patella out that way. And so if you can control the leg stance with glutes and core, they're more likely to have stable patella. So recurrent dislocation occurs in just one of these, I think. It can be up to 35%. So it's a pretty disastrous problem for people to develop. And around the world, there are huge research groups looking at it, and we don't have the right answer. So patellofemoral instability is something we just don't have great treatments for. So acute surgery, only if they've got a large fragment, as the kneecap has gone over, bang, it's taken out a bit of chunk of cartilage, and that's floating around in the knee. And can we repair it? Because your own cartilage is always better than scar tissue or fibrocartilage, or does it need to come out because it's a bit of grit in your gearbox? But definitely, if it's a large fragment, that's the one time we'd consider acute surgery, and then that's the time to refer to orthopaedics urgently. And then the risk of recurrence, it is variable. It can be sort of between 15 to up to 45, 50%. So it's huge in the unlucky patients with those malalignments and the ligamentous instabilities. So it's vital to keep going with those the rehab programs, and you can see the difference in the way they're standing. And this young lady here is at a higher risk because if you just we draw line vectors, and the quads, when it contracts, will automatically have a vector of force to pull the patella out, whereas this one is straight up, straight down. And the risk factors for recurrence are, so poor muscle control, as we said, the laxity of the medial patellofemoral ligament, and then rotational alignments and various other things that lead to this, which is what we look for. And how can we avoid recurrence? Compliance with the rehab, patella bracing, and I think the braces and taping can be quite helpful. And one of our physios here has actually got the problem, and he manages his knees quite well, you were saying. So definitely isn't something that surgery has to be done for everyone. And this is really, for me, I think, MRI in the acute setting, first-time dislocation, But then otherwise, investigation is usually arranged by us when we see the people in the rooms. And what we're looking for is a whole load of different things. So the high riding patella, so this is a normal position of a patella, and you can see how high that patella is sitting, and that automatically is going to allow their kneecap to pop out very easily. And then we often get an MRI. And if we're doing surgery for it, if it's an isolated traumatic injury, we can probably just do a ligament reconstruction of the MPFL. But sometimes with the people who have the other factors, we have to do quite major surgery with realignments and osteotomies, and it's huge surgery, and I'm not sure that it's ever been shown to. It often improves function and reduces dislocation, but it doesn't give people mechanically normal knees, because that's their mechanics as well, which are changing. So we definitely haven't got the right answer for how to deal with these just yet. And any questions? All right, so shall I try and play that? Does anyone want to see Q tracking video very quickly? J tracking, Q tracking, J tracking. So this is the normal right knee. I have patients' permission to take this video, and all the patients' patients have consented. So we can see relatively normal central tracking, and as we come up into full extension, you can just see that kneecap just tilting over to the side, just there, and that's J tracking. That's probably the simplest sign, and that is probably a sign not of a ligament injury, but of underlying mechanical abnormalities. So they've got trochlear dysplasia, they've got a lateralized tibial tubercle, allowing the quads to pull it over. All right, well, that's me done with my talk. Any questions?
So again, it's a 2-week window to repair it, is it?
For the cartilage?
No, the patella, the tear of the...
Yeah, so that's really controversial. Some people have been repairing them 2 or 3 weeks, and there's some research, but actually you don't have to do an acute repair for any patella dislocation. A lot of patients do very well without having any repair for their ligament. So I try to...
The ones on the MRI.
Oh, sorry. Quicker is better. 2 weeks ideal, but actually I've fixed them 2 or 3 months later. It definitely makes it harder. But I've done repairs of big cartilage fragments up to 3 months or 4 months later if we have to. Because younger patients, you just have to try your best to preserve the cartilage in their knees. Any other questions? Thank you very much, and thanks for not snoozing. It's hard on a Sunday morning. Thank you.